Good afternoon, everyone. Today I'm going to present role of paroxetine in anxiety disorder. Classification of anxiety disorders. It is classified into generalized anxiety disorder, specific social phobias, social anxiety disorders, agoraphobia, panic disorder, post-traumatic stress disorder, and anxiety disorder due to general medical conditions like hypothyroidism and substance-induced or withdrawal during substance anxiety disorders. Types of anxiety disorders. Anxiety symptoms usually most presently patient is not specific to any situation or object. It can occur anytime when exposed to a specific object, not exposed to any event or object or discrete severe anxiety. Severe anxiety when in vast open areas, exposed to severe traumas, had medical conditions like thyroid, hypothyroidism or hyperthyroidism, exposed to withdrawal of substance, or exposed to social situations. Usually distress and dysfunction are two of the symptoms which present during such situations. What is panic disorder? Panic disorder is a serious anxiety disorder. Individuals who suffer from panic disorder experiences panic attacks. These attacks are extremely intense, and people who have such experiences describe them as horrible and unforgettable. Commonly, a person suffering from this disorder remembers the time, date, and event occurring at the time of this powerful and overwhelming set of symptoms. And panic is an episode of intense fear of sudden onset. The fear often bordering to on terror, generally accompanied by unpleasant bodily sensation, difficulty in reasoning, a feeling of imminent catastrophe. Most of panic attacks are not associated with fear. A model of etiology of panic disorders. Biological vulnerability and psychological vulnerability. Biological vulnerability is stress due to which occurs due to negative life events. They're usually associated with interoceptive cues, which initially there is false alarm, then it is associated with interoceptive cues, and then learned alarm develops, which leads to psychological vulnerability. Then autonomic nervous system and cognitive symptoms of anxiety develop, leading to possibly development of agoraphobic avoidance. Diagnosis of panic disorder. It is unaccepted, unprovoked paroxysmal symptoms of anxiety. The duration is usually starting from 1 to 2 minutes, may last up to 1 hour. The frequency of attacks is 3 to 4 attacks per week, and usually 4 to 8 symptoms present during the panic disorder attack. The criteria for panic attack is palpitations, pounding heart or accelerated heart rate, sweating, trembling or shaking, sensation of shortness of breath or smothering, feeling of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheadedness or fainting, derealization, that is feeling of unreality or depersonalization, being detached from oneself, fear of losing control or going crazy, fear of dying, paresthesia, that is numbness or tingling sensation, and chills and hot flushes are present. The feeling of imminent catastrophe is that something terrible is happening to me. I feel that I'm in great danger. I feel that I'm about to completely lose the control. I'm going insane. I'm losing consciousness. I may fall with giddiness, and it would be very embarrassing for me. Epidemiology of panic disorder, lifetime prevalence, that it is 1.5 to 5% panic disorders. Panic attack is usually 3 to 5.6%, and 2.2% are limited symptoms, that is 1 or 2 symptoms are usually present in that case. Usually females have more, that is 2 is to 3:1 ratio, females occurring more than males. Precipitating factors, usually recent divorce or separations could be one of the reason. Mean age for presentation, usually below the age of 25 years, but can occur at any age, and usually underdiagnosed in children as they are not able to explain the symptoms properly. What the patient believes. People with panic believe very strongly that the attack they experience is due to physical or mental disease, medical disease, often due to partial knowledge of the disease. The medical evaluation of panic disorder is required for proper diagnosis. Usually the medical evaluation includes physical examination, blood test, and ECG. Sensors are placed on the chest to record the electric current of the heart so that palpitations or pounding heartbeat can be recorded. Further medical tests may be required, including further tests for heart functioning like 2D echo, etc., MRI for abnormality in brain structures, and EEG to sometimes seizure could be present, which could be diagnosed as panic disorder if not proper presentation of seizure is present. Components of management. Initially, reassurance is there as panic attack patient feels that he is going to die and won't be surviving. So reassurance is most important. Then pharmacotherapy and cognitive behavior therapy. In cognitive behavior therapy, cognitive restructuring, breathing retraining, interoceptive exposure, and situational exposure can be done. Psychological interventions. Psychological treatment is usually effective for panic disorders, reducing agoraphobic avoidance using strategies and based on exposure to feared situations. Exposure-based treatment arrange conditions in which the patient can gradually face the feared situation and learn that there is nothing to fear. Example, shopping in a supermarket for 30 minutes alone, walking 5 blocks away from home, driving on a busy way for 5 miles with a spouse or alone, eating in a restaurant or sitting in the middle, watching a movie or while sitting in a middle row. Psychological interventions, gradual exposure exercises combined with anxiety reducing coping mechanisms, example relaxation and breathing retraining. Usually PMR is useful in these conditions. 70% of patients undergoing with the treatment improve while their anxiety and panic are reduced and agoraphobia avoidance is greatly diminished. Effective of psychological treatment treat panic disorder directly even in the absence of agoraphobia. Panic control treatment, exposing the patient to panic disorder to a cluster of interoceptives, that is physical sensations that remind the patient of panic attack. Patients who received panic control treatment have remained better for at least 2 years have been found in many studies. Cognitive therapy, basic attitude and perceptions concerning of the dangerousness of the feared by objectively harmless situation are identified and modified in this. Pharmacotherapy of panic disorders. SSRIs are much better as compared to benzodiazepines and tricyclic antidepressants for long-term management of panic disorders. SSRI in panic disorders indicated for panic disorder, sexual dysfunction occurs in 75 or more people taking this. High potency of benzodiazepines, commonly used in panic disorder, works quickly but results in psychological and physical dependence and addiction. Usually when benzodiazepines are given, most widely used class of drug in practice, most motor and cognitive functions. 60% of patients with panic disorders are free of panic as long as they stay on drugs. 20% or more stop the taking treatment before the treatment is completed and rate of relapse are high among these patients. First is benzodiazepines, usually alprazolam, clonazepam or lorazepam are given, started with a dose of 0.25 mg and it is increased to up to 1 to 2 mg per day. They are rapid in action, well tolerated, but the concerns are that is they causes sedation, can't be used long term, could be used, need to be tapered in 4 weeks of time, as dependence could be created, and if long term used in high doses could control withdrawal symptoms also. Then tricyclic antidepressants, that is imipramine and clomipramine, usually started in low doses, but effective dose is 50 to 300 mg of imipramine and 75 to 200 mg of clomipramine for anxiety. Usually it is anticholinergic effects. The concerns are it is cardiotoxic, hypotension, weight gain, poor long-term compliance, and lethargy in overdose. 6 to 8 weeks for therapeutic benefits is required minimum. SSRIs, which are most commonly used for long-term use for panic disorders, most commonly paroxetine, that is 10 mg once daily, a dose of adjusting dose between 10 to 16 mg. It is well tolerated, better compliance, and low toxicity in long-term use. Fluoxetine is 10 mg 4 times a daily in doses of 20 to 80 mg maximum dose, and sertraline 25 mg 4 times a day, 50 to 100 mg adjusted dose in between. The important concern with SSRI are that they causes sexual dysfunction, which is the most concerning and discontinuation reason for the patients. Indications of paroxetine, except in compared to that is panic disorders. It was also used in other disorders such as major depressive disorder, obsessive compulsive disorder, social anxiety disorder or social phobias, general anxiety disorder, and post-traumatic stress disorder. Dose-based effect of paroxetine in panic disorder. The study was designed to determine minimum paroxetine dose effective for treating panic disorder. In this study, 425 patients with DSM-3 revised panic disorder with or without agoraphobia who underwent 2 weeks drug-free screening period, of which 278 patients were randomly assigned a double-blind treatment for 10 weeks course of placebo or paroxetine at a dose of 10, 20 or 40 mg per day. The four primary outcomes were to be believed coming, that is percentage of subjects free for panic attacks, mean change from baseline in number of full panic attacks, percentage of subjects with 50% reduction from baseline in number of full panic attacks, and clinical global impression score on the severity of attack or illness. That is dose-based effect of paroxetine. It was found that 40 mg paroxetine was more effective when compared to placebo to make patient panic free, and when compared to other doses also, that is 10 and 20 mg per day. In another random controlled trial, double-blind study on paroxetine versus placebo, while both group receiving standardized cognitive behavior therapy along with the drug. 7 centers in Denmark tested 120 as per DSM-3 defined paroxysmal panic disorder with or without agoraphobia subjects in a flexible dose protocol that is adjusted between 10 to 16 mg per day. 3 weeks of blind control placebo preceded 12 weeks of double blind treatment, and then 2 weeks of single blind placebo. The principal outcome of the study was the frequency of panic attack assessed during the panic inventory. It was found that there was more than 50% reduction in full panic attacks when given for more than 6 weeks, and zero panic attacks when given for more than 12 weeks. The number of full panic attacks were equal to par, that is paroxetine and placebo. Anxiety reduction is more with paroxetine at 6 weeks compared to this. Dropouts were equal between placebo and paroxetine both. In the two of the three primary outcome variables, there were more than 50% reduction in frequency of full panic attacks, which was more for paroxetine as compared to placebo. When paroxetine was compared to tricyclic antidepressant, that is clomipramine, in panic disorder, a 12-week double-blind parallel group placebo-controlled study was done. The objective is to compare paroxetine with clomipramine in 367 patients with DSM-3 and define the efficacy assessments were daily panic attack diary, the clinical global impression scale, Hamilton anxiety rating scale, Mark Sheen phobia scale, and Sheen disability scale. Paroxetine was found to have faster onset than clomipramine and was better tolerated. Thus, paroxetine is at least as effective as clomipramine in acute treatment of panic disorders. When the extended follow-up, that is the same, was continued for 36 weeks, the proportion of patients who withdrew from the study due to adverse effect was greater with clomipramine group than with paroxetine group. That is 19% people from the clomipramine group withdrew from the long-term follow-up, but only 17% from paroxetine group was withdrew. Or and placebo group also 9% people withdrew. This means that paroxetine was well tolerated by most of the people during long-term follow-up also. Paroxetine continuation relapse patients of panic disorders. Burnham et al. Have examined relapse rate on 105 patients who responded to a 10-week double-blinded paroxetine or placebo trial by re-randomization for further 12 weeks. Paroxetine-treated patients who were randomized to placebo relapsed significantly more often, that is 30%, than who continued paroxetine, that is 5% only relapsed. The side effects were similar seen at 10 first week and followed by 12 weeks. There was no change in the side effects. A short-term efficacy and tolerability of paroxetine when compared to placebo for panic disorders. A meta-analysis on random RCT was done. A total of 13 RCTs were included. The pooled analysis showed that patients receiving paroxetine experienced greater improvement in number of full panic attacks. More than 50% reduction was there in full panic attacks. There was also reduction in full panic attacks. The odds ratio was 1.70 for the same, and global clinical global assessment scale score was better than placebo when compared to this. So the study concluded that paroxetine is effective and well tolerated in short-term treatment for adults with panic disorder. SSRI in CBT resident panic disorders. Second step, stratified randomized design comparing two treatments SSRI, that is paroxetine and citalopram, were done, and continued CBD in a sample of treatment non-responder to initial course of CBT for panic disorder. Participants were randomized to 3 months of treatment and then followed by additional 9 months. Only treatment responders after 3 months were maintained on treatment until 12 months of follow-up. The data analyzed focused on panic disorder symptoms achieved a response status across first 3 months of the treatment. The improvement in total score was better for SSRIs, that is paroxetine and citalopram group, then continued to CBT alone. The dose indication of paroxetine in different disorders, that is major depressive disorder, the recommended dose is 20 mg per day, 20 mg per day, and maximum it could be gradually increased to 50 mg per day. For obsessive compulsive disorder, the recommended dose is 40 mg per day and could be increased by 10 mg to up to 60 mg per day, a maximum dose. For panic disorders, the recommended dose is 40 mg and could be taken up to 60 mg per day as maximum dose. And for anxiety disorder, that is social anxiety disorder, social phobia, general anxiety disorder, or post-traumatic stress disorder, the recommended dose is 20 mg and could be increased to 50 mg per day by increment of 10 mg for a period of time. What might be a typical treatment plan look like? Initially, we should provide reassurance to any of the patient coming with panic disorder, considering paroxetine 10 mg per day to increasing the maximum dose to 60 mg per day. Initially, we can consider benzodiazepines, usually clonazepam 0.5 mg twice per day for immediate relief, but need to be tapered slowly over a period of time, usually within 4 weeks. And taper all other sources of caffeine as they also may lead to anxiety. Take home message, that is panic disorder is a type of anxiety disorder which disturbs patients' life. SSRI are very effective and are first line drug for the management of panic disorders. Paroxetine is highly effective in panic disorders for both short term and long term. And paroxetine is better tolerated than tricyclic antidepressants in panic disorders. Thank you.